So, hello everyone, I'm Dr. Mahboob, your ophthalmology faculty, and this is the continuation series under INICET Power Pack Revision 2.0, Image Video 2, right? So, this section will be covering the retina, eyelid, orbit, and trauma. Now, we are going to discuss this first image. This is the schematic diagram where they have asked, what is this area? What is this area called? Okay, now you can see that below this area there is a hyaloid granules, and above this is nothing but this is ciliary body, right? So the area between the ciliary body and the hyaloid granules is known as canal of Patet. You know, this canal of Patet is nothing but the area importance it keeps, like this is the area where retrolenticular hemorrhage happens. This is the area where the retrolenticular hemorrhage happen, or this is the area from where the blood can enter into the lens through the tear or break in the posterior capsule. So the importance of this area. Now moving to the second image. Okay, this is, you can see, this is the histology of retina. What is this? This is nothing but this is the histology. This is nothing but this is the histology of retina. Now they will ask you this picture and they will say that what is something, they will ask what is this, what is that, what is that. Okay, they can mark you A, B, C, D, and they will ask which layer is this. So you know that there are the 10 layers of the retina, right? Okay, 10 layers of the retina. Okay, what are those 10 layers? Let me tell you those 10 layers. How will you remember? You will remember by just write IOP एंड IOP को ब्रैकेट में कर दो और यहाँ पे E और यहाँ पे 2 कर दो. Now from inner to outer, यानी कि from inner to outer if you go, it will be inner limiting membrane. Okay, so that means this area is nothing but inner limiting membrane. Okay, this is inner limiting membrane, right? This is nerve fiber layer. So the second point is the यहाँ पे inner limiting membrane होगा, ये inner limiting membrane हो गया. This area is nerve fiber layer. Similarly, G. So this area will be the ganglion cell layer. Now we have IOP. ब्रैकेट के बाहर में 2 है, तो I is 2 times, O is 2 times, P is 2 times, right? So I is inner plexiform and inner nuclear layer. O is outer plexiform and outer nuclear layer, right? After O we have E. So there will be external limiting membrane. This will be external limiting membrane. After that P is photoreceptor, so this will be a photoreceptor, and also second time P will be the pigment epithelium. So this way you can remember the mnemonics for the layers of the retina. Now when they will give you this histology, how to solve this. Remember only 3 layers of this. What are those layers you will remember? Remember this layer. This layer it is very much pigmented, so it is pigment epithelium. Okay, if you don't know about how, forget. You see where the nuclear type of thing is saying. You can see the nuclei type of thing here, यहाँ पे और यहाँ पे. ये in 2 places पे you can see the nuclei. So it is nuclei, it is also nuclei, right? अब चूंकि pigment epithelium is outside, that means this is outer side, this is inner side, so it will be outer nuclear layer and it will be inner nuclear layer. And when you know that this is inner nuclear layer and this is outer nuclear layer, by seeing only this goal, round nuclei here, you just imagine, you can assume or you can tell any layers. Okay, by knowing this mnemonic, INGIOP. If you know this mnemonic, so if it is inner nuclear layer, automatically this will become inner plexiform and this will become outer plexiform by this mnemonic. Okay, similarly this will become, this is the membrane, this membrane will become external limiting membrane and this will become photoreceptor. After, before inner plexiform layer, we have this one. So I can say this is ganglion cell layer. By this, now before this nuclear layer, so it will be a nuclear layer, or sorry, nerve fiber layer. This will be a nerve fiber layer. So whatever they will give you, whatever they will mark give you, just identify these two areas, this area and this nuclear area. After you identify this nuclear area, you can identify anything by just knowing this mnemonic. Understood my point? This is the representative photo that I have given you here. Okay, you got my point? In this photograph, what is need to be understand here? What is this cell? This is bipolar, right? Okay, this is the bipolar cells. This is very important to understand, and this bipolar cells is making connection with this. Understood? And now coming to the next MCQ. This is a very important electron microscopy picture of the photoreceptor cells. This is rod, sorry. This is rod and this is core. What you need to understand that the first question is mitochondria. Mitochondria is present in which segment? So basically photoreceptors is divided into outer segment and inner segment. This is very important to understand. There are the two segments of the photoreceptor. One is the outer segment, another is the inner segment. The question they have asked that mitochondria or endoplasmic reticulum or Golgi apparatus is found in which segment of the photoreceptor. So obviously this is the mitochondria and this is the endoplasmic reticulum. They are the picture of inner segment. So this is the important MCQ. Understood? Second important question that they have asked is disc पे. इस पे क्वेश्चन पूछा हुआ है. Where the disc is present in the rod or cone? Yes, this disc is present in the rod. So this is also an important MCQ, right? So this two MCQ is very important regarding the electron microscopy picture of the photoreceptors. Now moving to the next MCQ. So I have already discussed about these two instruments in the optical portion on the first part. This is nothing but, what is this? This is nothing but, this is the direct ophthalmoscope, right? And what is this? This is nothing but this indirect ophthalmoscope. Indirect, okay? ये indirect ophthalmoscope है. This is an indirect ophthalmoscope. Direct ophthalmoscope, indirect ophthalmoscope. I have already told you the difference. The important point to understand here is this photo. Is the important point that I want to show you. What is this photo is indicating? This photo is indicating that this person is doing here, whatever he is doing the B scan. This is the probe, B scan probe, and this is B scan is being done. So, and this empty area is vitreous cavity. Understood? Only I need to tell you that I have to tell you what is the procedure is being done here. Okay, understood? Now coming to this important thing. Here, I'm not going to tell you about the details of this. I'm just going to tell you what is which picture, which investigation. So this picture, if you see, that only the retinal vasculature is very much prominent here. So this is FFA. This is nothing but this is FFA. FFA का मतलब होता है फंडस फ्लोरेसेंट angiography. Similarly, when you see this picture, you can see something in the background is more prominent. So apart from these main vessels, from the background you can see some white hue very much. So this is, and this area is also black. Disc is also not appearing here. That means it is nothing but ICGA. ICGA का मतलब क्या होता है? ICGA simply means Indo-Cyanin angiography. Okay, this picture also similarly, this is also an FFA. Okay, this is also an FFA because of the retinal vasculature are more prominent and optic disc is seen here. Now, mota moti taur pe you need to understand these things. I am telling you one more important thing, that fundus fluorescein angiography basically depicts the retinal pathology. रेटिनल पैथोलॉजी के लिए इंपॉर्टेंट है, ठीक है, रेटिनल पैथोलॉजी के लिए ये इंपॉर्टेंट है, जबकि इंडोसाइनन एंजियोग्राफी इज इंपॉर्टेंट फॉर डिटेक्टिंग द कोरोइडल पैथोलॉजी, राइट, जबकि ये कोरोइडल पैथोलॉजी को डिस्क्राइब करने के लिए होता है. Understood my point? Now coming to the next. What is this investigation? This is the important MCQ of the last year Aims. INICET, sorry. This is nothing but this is an OCT. OCT of retina. So OCT is optical coherence tomography. So they depict all the layers of the retina. Now if they can depict all the layers of the retina, then tell me what are these things. Here in the retina you have this cystic spaces. This is nothing but CME. ये CME है, CME. इसका मतलब होता है cystoid macular edema. Got my point? What is this? This is, you can see, this is CSCR, that is central serous chorioretinopathy. Understand what is this? You can see something, some membrane is giving a traction, some membrane in the vitreous is giving that traction. So it's a vitreomacular traction, VMT, that is vitreomacular traction. One important thing I must tell you about the VMT, that most often the question have been asked over the VMT, what is the treatment? Treatment is straight away surgical, that is pars plana vitrectomy, or simply you can say PPV, pars plana vitrectomy. This is the treatment, right? Understood? Now coming to the next image. What is this investigation is saying? This diagram that I have made is the investigation known as ERG, that is electroretinogram. This is the wave. What is this wave? This wave, this is called A wave. This is called B wave, and this is called C wave. This is the B implicit time. ये जो होता है, this is nothing but it is implicit time. Implicit time. This is also implicit time. Okay. Now A wave is formed from what? A wave is the function of photoreceptor, that is rods and cones. B wave is a function of what? B for B wave, B for bipolar cells. It is a function of bipolar cells and Muller cells. Correct? C wave is a function of retinal pigment epithelium, RPE. So basically these all things are the function of different things. Now what is the importance of this? Importance is that in cases where there is a problem or there is a pathology of retina, these layers, these waves get diminished and can tell you about the diagnosis of the disease. Like in the retinitis pigmentosa, there is a diminution of this A wave mostly because of the rod cone dystrophy. Similarly, okay. Now what is this image? This image is multifocal ERG. It is most commonly a function of cones. ये cones के function को mostly दिखाता है. Function of, sorry. It is most commonly the function of cones. So basically it describes the macular pathology. Understood? So this is very important to understand all these things. Okay, you got my point? Coming to the next image question. Okay, now the fundus photo have been given here. I'm telling you the history. The patient is diabetic. The patient is diabetic type 2 and the patient present with this type of thing. I'm telling you, if I know what is this things, if you carefully see, then this area is microaneurysm. Okay, this sharp crystalline yellow, dark yellow, bright and with a very sharp, well-defined margin is nothing but hard exudate, right? You can see here. Okay, now somewhere if you see the areas where you have a fluffy margin, that is called soft exudate. Okay, soft exudate is also called as cotton. Cotton wool spot. Secondly, if you see here that there is a deep dot and blot hemorrhage. there is a deep dot and blot hemorrhage. Also, if we have a spread like thing कहाँ पे है? यहाँ पे देखो, यहाँ पे अगर देखेंगे, this will be like flame shaped hemorrhage. It's a flame shaped HMGH. Why I have written this in the sequence? Because I will tell you the feature of each and everything. First of all, come to microaneurysm. इसके बारे में बात करते हैं. Microaneurysm क्या है? Microaneurysm is an outpouching because of the leakage. Microaneurysm is nothing but it's a outpouching of the blood vessels. Micro outpouching of the blood vessels. So it is the earliest sign of diabetic retinopathy. What I have to write? यहां पे लिखना है earliest sign of diabetic retinopathy. Understood? Coming to the next point to understand here is that the microaneurysm is present in where this is present. So basically I have to tell you about the one thing that hard. Now coming to the hard exudates, we will talk about this microaneurysm portions later. Coming to the hard exudates are nothing but they are the bright yellow lesions, and they are the deposits of the lipoproteins having a well-defined margins, and they are present where? They are present at the outer plexiform layer. Similarly, this soft exudate, also known as the cottonwool spot, this is present in the nerve fiber layer, right? Nerve fiber layer. Dot and blot hemorrhage, this is present in the outer plexiform layer. And flame shaped hemorrhage, this is present in the nerve fiber layer. So you need to know about all these things. So one more interesting thing that I will tell you, that hard exudate and dot and blot hemorrhage OPL, soft exudate and flame shaped hemorrhage NFL, right? Now coming, so this is the diagnosis of this is nothing but it is NPDR, non-proliferative diabetic retinopathy. Now what you are seeing here, what is this picture? This is something we call it neovascularization. This is something we call it as a neovascularization. If this is a neovascularization in a case of type 2 diabetic patient, then the patient is labeled as PDR. PDR का मतलब होता है proliferative diabetic retinopathy. Understood? When you have a PDR, then the treatment is this one. तो आप इसका treatment ऐसे करोगे. What is this? This is pan retinal photocoagulation or PRP. Understood? So this is about the non-proliferative diabetic retinopathy, microaneurysm, hard exudate, soft exudate, and proliferative diabetic retinopathy. Whenever you see a neovascularization in the fundus of a diabetic patient, then it is a proliferative diabetic retinopathy and you need to laser that portion. So this is the treatment here. Understood? Moving to the next. See, what is this picture indicate? Whenever I am telling you, whenever you see the subhyaloid hemorrhage, this is the subhyaloid hemorrhage. How to identify the subhyaloid hemorrhage? Subhyaloid hemorrhage की एक पहचान होती है, उसका नाम होता है, we call it boat shaped hemorrhage. अगर boat shaped hemorrhage है, if there is a boat shaped hemorrhage, like boat यहाँ पे है ना ऐसा, if I can tell you it's like a boat. If it is a boat shaped hemorrhage, this is subhyaloid hemorrhage, right? Subhyaloid hemorrhage. And when there is a subhyaloid hemorrhage, what is the treatment? Cause can be anything. Cause can be because of trauma, because of Valsalva's procedure. This can be the cause. But whenever it happens, what is the treatment? The treatment is YAG, just like the YAG PI, YAG peripheral iridectomy, na? Just like that only. You use the ND YAG laser and you do YAG hyaloidotomy. You do this hyaloidotomy. ठीक है, आप इसको YAG hyaloidotomy करोगे. ठीक है, when you do the YAG hyaloidotomy, there will be a gush of blood coming from this area and it will drain. And after draining, what happened after draining? This picture will be there. Only the few portion of the blood will remain here. Rest of them will go, and the patient will again gain the vision. So basically, if you see the boat-shaped hemorrhage, take it as subhyaloid hemorrhage, and the treatment that you will give is the YAG hyaloidotomy. It's very important. Okay. Now coming to this picture, can you see what is this and can you tell what is this? In this picture, you can see, I am telling you what you can see here. Just observe me. There is nothing random in ophthalmology. Everything there's a sign. Okay. You see, this blood vessels has become tortuous like this, and the thickness of the blood vessels. You see the thickness so much thickened. Compare with this blood vessels. These blood vessels are so much thickened. So there is a tortuosity, there is a thickening of the blood vessels, and there is a hemorrhage here, everywhere, like a tomato splash appearance. So it will be like a tomato splash appearance or tomato ketchup appearance. So what is this? This is, the diagnosis is CRVO, that is central retinal vein occlusion. Okay. Now, if you look at it carefully, what you are getting the hemorrhage only in this area. A quadrant of the area is involved, a quadrant or part or a portion of the retina is involved. Okay? This is the diagnosis in this condition is the chota bhai of this is BRVO. BRVO is nothing but branch retinal vein occlusion. That's it. So basically, I'm telling you all those two things that is important, CRVO and BRVO. Okay, they can give you, and this tomato ketchup, tomato splash appearance, all that you need to know for the one-liners, right? Now, coming to this picture, FA of a diabetic patient is done. I'm telling you, this picture is adhura. This picture is half only. So I'm giving you the full history. This is the FFA of diabetic patient. FFA of a diabetic patient. So what is this small area? This is big. This is the hyperfluorescent. What I can call it? I can call it hyperfluorescent dot. It is this hyperfluorescent dot is because of the leakage. Okay, and this indicates microaneurysm. This indicates microaneurysm. They have asked you this microaneurysm on FFA appear as hyper so microaneurysm on FFA appear hyperfluorescent dawn. This is an MCQ. Okay, you have to understand this point. Now coming to this is a very important. As I already told you, if you see this OCT image, this is an OCT image of what? Retina. Yes, this is an OCT. This is an OCT of retina. OCT is optical coherence tomography of retina, and you can see there is a cystoid changes, cystic lesions. This is cystic spaces, and this is nothing but cystoid मैकुलर इडेमा, जिसको हम लोग शॉर्ट फॉर्म में CME भी बोलते हैं. And when you do what? When you do the FFA, then FFA जब करोगे, then this type of image is coming like this. You can see here. What is this? This is nothing but petalloid appearance. So on FFA of CME, you have a petalloid appearance. So when they ask you that OCT of retina is showing the CME, what is the appearance of the FFA? This will be the petalloid appearance. This is very important to understand. Got it? Coming to this patient. This is a hypertensive patient, right? If this is a hypertensive patient, then what is the grade of this patient? Okay, can you see here? Can you see here? There's a disc edema. So there is a disc edema. Okay, and can you see here? This is a hard exudates causing macular starring. Macular star because of hard exudate, right? So when there is a hypertensive patient plus disc edema plus macular star, then what is this? The diagnosis is grade 4 hypertensive retinopathy. Okay, it's a grade 4 hypertensive retinopathy, or also we can say malignant hypertensive retinopathy. So what you need to do in this condition, you need to lower down the blood pressure or hypertension you have to treat. When you treat the hypertension, this picture will reverse. Believe me. Now the few things related to this condition. There are so many classifications related to the hypertensive retinopathy. The first classification that you should know is the Keith-Wagner classification. Okay, Keith-Wagner classification. And in this, because of this classification, this grade 4 is there, right? Second classification is SHE classification, SHIE, C classification. Why I am telling you the C classification? Because sometime they will ask you the grade of copper wiring, the grade of silver wiring. So you have to answer. So in this C classification, they have mentioned copper wiring. Copper wiring. So copper wiring is seen in grade 3. Understood? According to this classification. And silver wiring is seen in grade 4. There are so many things like Salu sign, gun sign, and bonnet sign. They are also have to be discussed under this hypertensive retinopathy, but this is beyond this, beyond the level of this lecture. We will be discussing all these things in the later one. Okay, so this is about the hypertensive retinopathy. Understood? Now coming to this very important point to understand. Can you see the OCT of this retina? Here it's a space. Here it is just central space, right? If you see this type of picture, then the diagnosis is straight down to CSCR or CSR. CSCR is central serous chorioretinopathy, or you can also say CSR only. When you do the FFA, जब आप इसकी FFA करते हो, FFA, then you got this picture. What is this picture? This picture is indicating smoke stack appearance, and this picture is enlarging ink blot sign. So this smoke stack appearance, enlarging ink blot sign are the features of the CSCR. Important point to understand here that in this ink blot technique, it is the most common. It is more common. One important point to understand: what is one thing you want this type of patient to avoid? What is one thing you want this type of patient to avoid? I will ask this patient to avoid steroid, any type of steroid, and stress. That means steroid and stress are the causative factor for this CSCR. So avoid steroid and avoid stress. Understood? Now coming to this OCT, a very simple question, that this OCT is indicating nothing much to discuss here. FTMH. FTMH बोले तो full thickness macular hole, and this is the fundus diagram of full thickness macular hole, right? Understood? Now treatment is surgery only. It will not heal by itself. What is this picture indicate? क्या है ये पिक्चर का राज? समझो, बात को समझो. If you see carefully, what you will observe here, you will observe there is some cracks. Can you see the cracks here? ये देखो crack, देखो ऐसे ऐसे गया है crack. So these cracks are nothing but angioid streaks, and these angioid streaks are nothing but it is the break in or breach in Brooks membrane. Now you will ask, what is Brooks membrane? It is the membrane between the retina and the choroid. There is a membrane between the retina and choroid that is called the Brooks membrane. And when there is a breach in the Brooks membrane, this angioid streaks is formed. What is the cause of this Brooks membrane? Cause of angioid streak. Angioid. The cause of angioid streaks are Pepsi. P for pseudo xanthoma elasticum. E for Ehlers-Danlos syndrome. P for Paget's disease. S for sickle cell anemia. I for idiopathic or iron deficiency. So basically, this angiodystric is caused by the pseudoxanthoma pepsi is the pneumonic, pseudoxanthoma elasticum, Ehlers-Danlos syndrome, Paget disease, and sickle cell anemia, idiopathic or iron deficiency. Among them, the most common is, this is the most common cause. So pseudoxanthoma elasticum is the most common cause. Now, can you see this? What is this picture indicates? If I carefully see this picture, then I am finding here it is bony pigmented spicules. What is this? This is waxy pale optic disc. And what is this? This is arteriolar attenuation. So bony specule plus pale waxy disc plus arteriolar attenuation leads to what is the diagnosis? So diagnosis comes here, retinitis pigmentosa. So retinitis pigmentosa is a triad of the three things, that is pale waxy disc, bony pigmented spicules, and arteriolar attenuation. So what you need to understand here is what is the most common association, syndromic association of this. So association जानना बहुत जरूरी है. तो let's see. ये important है because they have asked the question on this association of RP. This is also known as RP, right? So RP का association होगा. What are the RP association? The first, the most common association is Usher syndrome. Usher syndrome. Usher syndrome में RP plus, sorry. Usher syndrome में there will be the RP plus sensory neural deafness होगा. So they can ask this question because this is the most common association. Other things that you need to know is Refsum's disease. Refsum disease, Lawrence Moon-Biddle syndrome, और क्या होगा? Baston Conch-Weig syndrome. It is also known as A beta lipoproteinemia. So these are the few associations that you should remember about the retinitis pigmentosa. Understood? Now coming to this picture. This picture, can you see what is this? This is an egg yolk-like appearance. When you see an egg yolk-like appearance on the fundus, especially at the macula, so I can write here, this is like egg yolk-like appearance. Egg yolk लीजन है, इसको क्या बोलते हैं? इसको बोलते हैं वाइटेलिफॉर्म लीजन. वाइटेलिफॉर्म lesion. And in which condition that you see the viteliform lesion? Best disease. You see this condition in the best disease. So what is the gene associated? इसमें दो तीन question important है. That is the gene associated is VMD2 gene mutation. They form a protein called bestrophin protein. This is also an MCQ. Now if they have asked this, here in this condition what is happening? ERG तो normal होगा, but EOG is decreased. less than 150. So if this is the condition, they can ask you this ERG is normal, EOG is decreased, then the diagnosis again comes best disease. This is the most common MCQ that they have asked. So this is about this lesions. Now coming to this condition, see here something is seen in the retina. ये देख रहे हो आप देख रहे हो, ये देख रहे हो, something is seen in the retina. This normal fundus look, but this is not normal, and you can see some tear. This is hole. तो ये hole हो गया है retina में, और ये वाला जो area है, this area is detached. ये detached retina है, and this is attached retina. So basically, I am dealing with the retinal detachment, and this is rhegmatogenous type. Okay, this is what type? Rhegmatogenous type. Okay, you see the corresponding B scan. This is the retina detached. Okay, only attached at the optic disc. What will happen? What are the other things, other questions they can ask you? They can ask you that in this condition they will have a curtain falling curtain sign. Falling curtain sign. If in the question they are asking that there is a falling curtain sign, remember that this can be rhegmatogenous retinal detachment. Okay. Second thing, that there is a difference between the fresh retinal detachment and the old retinal detachment. If there is some signs like, what are the signs of old retinal detachment? अगर old RD है, I can call it RD na, retinal detachment. If there is an old RD, that means there can be a demarcation line. There can be a subretinal band or PVR changes. PVR changes means proliferative vitreoretinopathic changes. So these are the few things. If question is saying that the demarcation line is an old RD, subretinal bands, it's an old RD. Okay. Now coming to this. So moving on to the next image. This image you can see of a child and having a unilateral leukocoria or white reflex. This is called white reflex, or white reflex को हम लोग बोलते हैं in the term of what we call it leukocoria. We call it leukocoria. So there are so many examples of other causes of leukocoria. Among them, the most common are, one, सबसे पहला जो दो तीन चीज आपको याद रखनी पड़ेगी, leukocoria can be because of unilateral, not unilateral, but because of the cataract. Okay, because of the cataract. It can be because of cataract, right? Congenital cataract बोल सकते हो उसको. दूसरा, why it is that? दूसरा important cause होता है retinoblastoma, right? The third important cause is Coats disease. The fourth important cause is PHPV, means persistent hypoplastic primary vitreous, right? So there are so many other causes, but this important causes you have to remember. So looking at the image of this leukocoria, you can deduce, like, it can be because of cataract, congenital cataract, it can be because of other things. But if they are giving such a history, like they have this type of or previous history of some tumor, then you can remember like that. What is this histopathology and what is this histopathology? As you can see, if you can see carefully, there are the nucleus all around with the lumen empty lumen agar hai, then the diagnosis of this condition, the empty, this is known as flexor, it will come like this is known as flexor winter Steiner rosette. Remember, there are the nucleus all around with the empty lumen. Now, if there is no empty lumen but filled lumen with the nucleus all around, this is called Homer Wright rosette. This is called Homer Wright rosette. So in retinoblastoma, in this condition, we found these two types of rosette, right? Other than that, we have the pseudo rosette is also found in the retinoblastoma. So let's talk about something about the retinoblastoma. Retinoblastoma gene is 3p. रेटिनोब्लास्टोमा में जो सबसे इंपॉर्टेंट चीज है, मोस्ट कॉमन इन less than 3 years of age. Understood? Most common symptom, most common sign is leukocoria, and it is about 60%. Understood? Second most common cause is strabismus. So why I am writing this strabismus is because these two are very important as far as this is the science of this concern. Now let me tell you one thing, that this retinoblastoma and this Coats disease can be differentiated on B scan based on one thing, that is this retinoblastoma has calcification. Okay, calcification is a feature of retinoblastoma, and this no calcification, right? So this is all about the retinoblastoma that you have to learn. Coming to the important point to understand here. Now coming to this, now we have completed almost every images of the retina. Now we are moving to the lacrimal apparatus or vital wala part or eyelid wala part. Now looking at the picture, what is this instrument used for? Basically this instrument is known as, what is this known as? Okay, just think in the mind. Okay, if you have thought in the mind, then I am writing it here. It is called bone punch. Bone punch means this will cut the bone. Okay, what it will do, this is used in dacryocysto-rhinostomy. In DCR operation, this is used. After 3 years of age, we can go for the DCR operation, right? So this is basically used in the DCR operation. Okay, what happened in the DCR operation? It creates or it cuts the lacrimal bone. Okay, it will cut the lacrimal bone and create passes between lacrimal sac and nasal mucosa. But where in the nasal mucosa? Middle meatus, understood? Where in the lacrimal sac, right? So this is about the bone punch. Coming to this picture. So what is this? Actually, this is the lacrimal apparatus. So I have to write each and everything. So this is nothing but this is lacrimal apparatus. Now what is this? The first one, what do you think? What is this? This is lacrimal gland, and since this is a lacrimal gland, the position is superotemporal. So remember the position of the lacrimal gland. What is this? This is nothing but canaliculi. Understood? What is this? This both canaliculi is forming a common canaliculi. So this is nothing but it is a common canaliculi. Understood? What is this point? ये point क्या है जहां पे ये indicate कर रहा है arrow? This is nothing but this is puncta. This is upper punctum, lower punctum. From here, with every blink, this will go into the tear will go into this sac. So what is this area? ये area कौन सा है? Or I can say what is this area? This area is lacrimal sac. What is this area? It is nothing but it is nasolacrimal duct. And what is this area? This is called valve of Hasner. Remember, this valve of Hasner is not a true valve. It is not a true valve. It is just a mucosal flap. So I am writing here, it is not true valve, just a mucosal flap. Understood? Second point to understand about this nasolacrimal duct. Direction of the nasolacrimal duct, very important. Direction of the nasolacrimal duct. As you can see, this is going down. This is going down and laterally. Down, posterior, down, anterior and laterally. Sorry, downward, backward and laterally. So remember by the DBL. Downward. How will you remember this? You should remember this with DBL. DBL. जैसे IPL होता है ना, वैसे DPL याद रखो. Downward, backward and laterally. So DBL. So remember this with the help of the DBL. Okay. Lacrimal sac may we create a hole and then it enters into the nasal mucosa during dacryocysto-rhinostomy that I have already discussed, right? Now, coming to this, what is this? What is this going on here? Bowman's probe बोलते हैं इसको. This probe is nothing but Bowman's probe. So what is being done here? Here probing is being done. Probing is being done. When we do the probing, the indication of probing is congenital nasolacrimal duct obstruction. जिसको हम लोग बोलते हैं NLDO. When there is a congenital nasolacrimal duct obstruction, then the probing is done. So basically what is happening, up to 9 to 12 months, we try to do Crigler massage. Suppose a patient of congenital and nasolacrimal duct obstruction comes. So you will start, the first treatment that you will start is Crigler massage. So you give the Crigler massage up to 9 to 12 months. So 9 to 12 months तक आप इसको Crigler massage दोगे, followed by आप probing करोगे after 1 year almost. जनरली हम 6 to 9 months बोलते हैं, 9 months के बाद करते हैं, बट 1 year के बाद जनरली करो. After probing, even it is not after 2 times probing is done, 2 times, remember, 2 times probing is done, then you have to think of that it is not going to be corrected by this probing simply. So you have to do some surgical. Surgically treat करने के लिए you have to wait for some time, like 3 years you have to wait. So then you go for the DCR operation. Almost more than 3 or 4 years of age is very important to understand here. So this is nothing but it's a Bowman's probe. कौन सा probe है इसका नाम? Bowman's probe है ये. So understood what is being done here. Now what do you see here? See, there is something here that is swollen and it is, ये swell किया हुआ है ना एरिया, ये nose है. So something beside that, यहाँ पे क्या है? So if I am writing what is here, यहाँ पे क्या है? अगर मैं इसको बता दूं कि यहाँ पे पंक्टा है, यहाँ पे पंक्टा है, and because of this punctal area it is swollen. So what is this called? Here the diagnosis is congenital dacryoceal. ये diagnosis है. In this congenital, because it looks like congenital, बच्चा दिख रहा है ना ये, eyebrow से देखो, eye से देखो, it looks like a congenital dacryoceal. So in this condition you have to treat with the systemic antibiotics only. Understood? Now what is this? This is very highly inflamed thing. देख रहे हो आसपास में कितना ये इन्फेक्शन हो गया है, वो सील है, वो है बट वो कॉन्जेनाइटल है एंड इट्स लॉन्ग टर्म, बट ये इन्फेक्शन हो गया है. यहां पे इसको बोलते हैं congenital, sorry, it's not a congenital, it's a acute dacryocystitis. Acute dacryocystitis. Remember this, that this is acute condition, so no surgical intervention. One, and second thing is that systemic, चाहे वो ओरल हो या आईवी हो, एंटीबायोटिक्स देना है. ओरल और आईवी एंटीबायोटिक्स. अंडरस्टूड? नाउ व्हाट इज दिस इंस्ट्रूमेंट? समटाइम क्या होता है ना, समटाइम व्हाट हैपेंस व्हेन यू हैव अ एपिफोरा. एपिफोरा मींस, एपिफोरा एक टर्म है. एपिफोरा, एपिफोरा का मतलब होता है एक्सेसिव वाटरिंग फ्रॉम आई. सो वाटरिंग फ्रॉम द आई ज्यादा होता है, उसको इपिफोरा बोलते हैं। तो इपिफोरा का जो काउज होता है वो समटाइम्स सिर्फ पंक्टा होता है, पंक्टा क्लोज हो जाता है, only the puncta that is present here. I will draw, एक चीज बनाता हूं मैं यहां से, अगर इसको नेजोलैक्राइमल सिस्टम बनाया जाए तो कैन यू सी दिस नेजोलैक्राइमल सिस्टम? सी, सो ये नेजोलैक्राइमल डक्ट सिस्टम हो गया। सो बहुत बार दिस इज कॉल्ड अपर पंक्टा, दिस इज लोअर पंक्टा। सो व्हाट हैपेंड, टीयर्स इज कमिंग in tears from the eye enters into the puncta and it goes here and comes out through the nose. So most of the time, most commonly, this puncta get closed because of infection, because of inflammation or anything else. So the only treatment that we can do, we can open the puncta. So the one more important thing, that because of the stenosis of the puncta, if epiphora is happening, we can simply dilate this. So to dilate the puncta, we need this instrument. What is this instrument? This is called punctum dilator. इसका नाम क्या हो गया? इसका नाम हो गया punctum dilator. What is the name, full name? Nettle-Sip punctum dilator. So it becomes Nettle-Sip punctum dilator. Understood the point? अब इस point को हटाते हैं सर. Coming to this point, can you see this strip? What is this investigation is going on here? The investigation that is going on here is, this is called Sirmer strip. Sirmer strip, understood? Sirmer strip is made up of Watman filter paper 41. This number is very important. So this procedure is the Sirmer test is being done. Sirmer test में, to know the, in case of dry eye, we do it in the case of dry eye, quantity of tear film के लिए करते हैं। दो तरह का होता है। Sirmer test is of two types. Actually 3 type होता है। Sirmer test mostly 1, 2 and 3. With in the 1, no anesthesia is used. यहाँ पे anesthesia यूज करेंगे. In the 2 we use the anesthesia, and in the 3 it is done with Valsalva. Understood? So if they ask you, type 1 Sirmer test is without anesthesia, normally we perform this. Second is with anesthesia, third is with Valsalva. So the value that we are normally doing here in the OPD, what we are doing here, this one. So with the 1 we have that 3 types of test. More than 15 it is normal, 10 to 15 mild dryness, 5 to 10 moderate dry, and less than 5 severe dry. So this is about the Sirmer strip. You don't need to remember everything. Just remember Sirmer strip is this. This is made up of the Watman filter paper 41. This is for the dry eye and quantity of the tear film. This much is enough for you, I think. But if you want to know more and somewhere it will ask, then you can remember all these things also. Now what is this? What is this test is done? Again, a very important question that they have asked. This does not look, this is done for dry eye to quantify tear film. Understood? Then what is this? Although this strip does not look red, it is, this test is phenol red test, and this thread is phenol red thread. Understood? Got it? Moving to this point, very important. You just not need to go anything, just remember only facts. What is this? I have already told you in my first portion where we have discussed, जहाँ पे हम लोगों ने we have discussed the coloboma. There only I have described that this one is nothing but upper eyelid coloboma, and the most important complication and the most common complication that can happen here is exposure keratopathy. Understood? Coming to this point, this is the very important to understand that this patient is having no eye. You cannot see anything because eyelid has not been formed. तो उसका जब eyelid ही नहीं बना है तो how can you expect anything? So basically this condition is known as cryptophthalmos. Understood? Good. Now coming to this, can you see what is this? If I say it is a painless nodule, अगर मैं इसको बोल देता हूं it is a painless nodule, right? painless है. Can you see this nodule here away from the lid margin, round? So the diagnosis will be, क्या हो गया diagnosis? Yes, Calazian. Calazian is nothing but it's a lipogranulomatous suppurative lesion. Lipogranulomatous suppurative lesion, right? ये लाइपोग्रानुलोमेटस सुपरेटिव लीजन है. ये भी क्वेश्चन पूछा है, ये भी क्वेश्चन पूछा है. अंडरस्टूड? what is the duct or the gland is involved here? It is because of the obstruction of meibomian gland. तो ये इंपॉर्टेंट है. Similarly, if I say this is painless away from the disc margin, lipogranulomatous because of the meibomian gland involvement. Remember, Calazian is a painless involvement of meibomian gland. If I say, painful inflammation of meibomian gland leads to, क्या होगा? आंसर internal hordeolum. Understood? So painless inflammation of meibomian gland is Calazian, and the painful inflammation of the meibomian gland is internal hordeolum, right? Then if I am talking about the internal hordeolum, तो मुझे बात करनी पड़ेगी external hordeolum के बारे में also. So what is external hordeolum? External hordeolum is also known as style. Now it is the inflammation of Zeiss and Moll gland. Understood? Painless inflammation of meibomian gland is Calasian. Painful inflammation of meibomian gland is internal hordeolum. And external hordeolum is inflammation of Zeiss and Moll. So, Calasian is only painless. Both of them, hordeolums are painful. Got it? Coming to this point. Coming to this point, what you see here, if you see carefully, this is one row of eyelashes, this is the other row of eyelashes going on. So extra rows of eyelash, extra row of eyelash is called, tell me, dystichiasis. So many times have been asked in the examination. So this is very important. Got my point? अब हम आगे चलते हैं. Dystichiasis. When the eyelashes is rubbing your cornea, this is called trichiasis. See this and see that. थोड़ा आइडिया लगाना होगा. Puffy, eyeball, congested, cornea बहुत बित्तू सा. I mean, it's very small looking. So much periorbital swelling here. This is because of the inflammation of the septum, orbital content. So this condition is called orbital cellulitis, and treatment is only IV and oral antibiotics. This is one of the emergencies in ocular pathology. It's an ocular emergency. It's very important to aggressively treat this, otherwise the infection can spread. Okay, now coming to this point, what is this? This is an eyelid. Yeah, eyelid hai. What is this? This is the umbilicated type of lesion. ये एक umbilicated lesion है. Umbilicated lesion. So if you have read in microbiology some virus which can cause umbilicated lesions, or also in dermatology you have seen. So this is nothing but caused by the molluscum contagiosum. So this is found because of the organism called molluscum contagiosum. Understood? देखो ये क्या है. दिस इज एन MRI. सबसे पहले समझने वाली बात है कि व्हाट इज दिस. सबसे पहले समझने वाली बात है कि दिस इज नथिंग बट दिस इज एन MRI. ये MRI है, राइट? दिस इज एन MRI where you can see there's a hyper intense lesion is found in here. What is this side? This is superior temporal area. Obviously this is superior temporal area. That means यहाँ पे जो structure होता है, what is the most common structure that I have already told you? Obviously ये जो structure होता है वो किसका होता है? Lacrimal gland का. So ये जो structure होता है वो lacrimal gland का होता है ना. So this structure is because of the lacrimal gland. So something is happening here. Actually, there is a tumor here. Now you have to predict what is the most common type of tumor. Nothing to remember like that. This is a very homogeneous lesion. So the most common tumor that is responsible for this homogeneous type of hyperintense lesion on MRI is nothing but pleomorphic adenoma. So the answer for this MCQ will be pleomorphic adenoma and nothing else. Okay. क्या हो रहा है यहाँ पे? What is happening here? What is the procedure is being followed here? A very simple procedure that is being followed here is this process is for proptosis, and here the instrument that is being used is Hertel's exophthalmometer. So ये exophthalmometer है which is being used here. Understood? Exophthalmometer. What is the other exophthalmometer that is being used? That is commonly being used. That is called Leudes exophthalmometer. Okay. So you should know the name of these two things. A Hertel's exophthalmometer and the Leudes exophthalmometer. And this is to measure the proptosis. Proptosis ये measure करता है if there is a difference of the two eyes, it can measure this. Or singly, if there is an increase in the protrusion of the eyeball from this margin, lateral or orbital margin, more than 21 millimeter, it is known as proptosis. Understood? Basically, यहाँ पे आपको इतना समझना है कि this picture is of Hertel's exophthalmometer and nothing else. Now, this is a thyroid patient and having this type of CT scan. If you see carefully, then you will find that there is a fusiform enlargement of this muscle and also this muscle. Okay, so when there is in a thyroid patient, there is a fusiform enlargement. अगर fusiform enlargement होता है किसका? Of extraocular muscles का, then it is strongly indicates thyroid ophthalmopathy. Understood my point? It is known as thyroid ophthalmopathy. So what is the most common muscle? Or I can write first extraocular muscles involved. कौन सा होता है? वो होता है inferior rectus. This is also a very important question. So this is nothing but this is a fusiform enlargement of this thyroid patient having a thyroid ophthalmopathy of the first extraocular muscles involved in the inferior rectus. One more important thing, agar there is a history of a patient having a thyroid ophthalmopathy or something like that, they will ask that the patient can be euthyroid or not. Yes, patient at that time when you are seeing the patient may be euthyroid. It does not mean that the patient should have high thyroid. Okay, so to be diagnosed, you should not be euthyroid. The patient can be euthyroid at the time of presentation. Understood? Now, what is this? This picture is very important. Understood my point? See, when you are seeing here, sorry, When you are seeing here, this is ptosis. Understood? You can see the ptosis at the margin of the pupil. This is the light margin and this is the lid margin. So it is ptosis. When he is opening his mouth, the ptosis gets corrected. So I can write ptosis corrected. What is this phenomena called? This phenomena is known as Marcus-Gunn jaw winking phenomena. This is called Marcus-Gunn jaw winking phenomena. Understood? If I am telling you that this is the Marcus-Gunn jaw winking phenomena, why is this happening? क्यों हो रहा है ऐसा? Patient open कर रहा है mouth, means our pterygoid muscles is being something happening. So basically, what is happening? There is a misdirection of the cranial nerve fibers. Misdirection of the cranial nerve fibers. Which fiber? So I am writing here, it is because of misdirection of cranial nerve fibers. किसका? फिफ्थ का थर्ड में, मतलब मिस डायरेक्शन ऑफ फिफ्थ क्रेनियल नर्व फाइबर टू थर्ड क्रेनियल नर्व फाइबर. इसमें भी LPS को सप्लाई करने वाला फाइबर, एंड दिस थर्ड इज सप्लाइंग द LPS. ऑब्वियसली इट विल गेट करेक्टेड व्हेन यू आर ओपनिंग द माउथ. The fifth muscle, the fifth cranial nerve is working, is stimulated, and the fibers from this is misdirected to the third oculomotor nerve, which is supplying the LPS, and that's why LPS also contract. Very simple. Understood point? So this is Marcus-Gunn jaw winking phenomena. Now that's the end of the images, which is very important for the orbital part, right? Or lacrimal apparatus. Now we are coming to the trauma part. Trauma images are very important, but there are only few images that they can ask, and they are asking repeatedly. Okay, so let's concentrate on that part. So this is the CT scan of a traumatic patient. So what is you are seeing here? You can see that there is something suspended here, and this is maxillary antrum. This is maxillary antrum, right? So in the maxillary antrum, right side में something is suspended. This is nothing but oil droplet sign. इसको क्या बोलते हैं हम लोग? Oil droplet sign. And this oil droplet sign is because of the herniation of orbital fat into the maxillary antrum through or via the break or fracture in the orbital floor. So यहाँ पे orbital floor का fracture हुआ है. Orbital floor fracture. It is the most common. Orbital floor is the most common wall orbital wall to get fracture in blunt trauma. Understood? So basically this is happening that the maxillary antrum में ये orbital fat is herniating because of the fracture of the orbital floor. ये orbital floor fracture कर गया है. So it is all droplet sign, orbital floor fracture, and the orbital floor is the most common floor to get fractured in the blunt trauma. This is also an MCQ. Now, if I am saying that this picture is, I have observed this picture in a patient when after the blunt trauma. So after the blunt trauma, if you are seeing this type of picture, then what you are suspecting? This is nothing but, this is the osseous ring. And this formed because of the imprint of the pupillary margin on the anterior capsule during the trauma. Understood? Similarly, there are so many signs. Let me tell you one important image. After the trauma, the patient comes with this pupil. This is the normal pupil, and this is something D-shaped pupil you are seeing. It's not D-shaped. It's not good, because what happens, there is a what happened here is that there is a disinsertion. This iris is disinserted from its root. So what happens here, iris disinserted, इसको बोलते हैं iridodialysis. Understood? Similarly, अगर एक patient है, some trauma is happening to his, and patient presented with this type of picture, then what you will observe, what you will tell? I will tell there is something here. What is this? This is nothing but a foreign body. If you see a foreign body, what will you do? The very first thing, removal of foreign body. And how will you remove it? You will remove it with the help of 26 gauge needle. So you will remove this with the help of the 26 gauge needle. This is about this. Now, so only few pictures they have asked in the examination. However, 1-2 things like ceruloplasmin, siderosis type of picture they have asked, but we have discussed it into the separate third video. Okay, so don't worry, we will be discussing everything. Stay tuned, watch the third video. Okay, thank you.